The harmful effects of marijuana in pregnancy, NU 661, Primary Care of the Childbearing Woman, Dawn M. Jenkins. Substance abuse in pregnancy. Substance abuse refers to the harmful or hazardous use of psychoactive substances, including alcohol and illicit drugs, during pregnancy. Psychoactive substances use can lead to dependence syndrome. Dependence syndrome is a cluster of behavioral, cognitive, and physiological phenomena that can develop after repeated substance use. A strong desire to take the drug makes it difficult to break the habit. Marijuana is a dry, shredded green and brown mix of leaves, flowers, stems, and seeds from the hemp plant Cannabis sativa. In a more concentrated resinous form, it is called hashish and as a sticky black liquid, hash oil. The main psychoactive chemical in marijuana is delta-9 tetrahydrocannabinol. According to a 2017 national study on drug use and health, marijuana is considered the most commonly used illicit drug. Marijuana is the most common illicit substance used during pregnancy. Prevalence of marijuana use during pregnancy varies according to maternal age, race, or ethnic background, and socioeconomic status. Substances such as marijuana and hashish that are not medically prescribed are considered illegal. Epidemiological factors. In the United States, marijuana used by pregnant women appears to be increasing. A review of national survey data reported that rates of marijuana use increased from nearly 3 to approximately 5% during 2002 to 2016. A study from the United States National Survey on Drug Use and Health database reported that the percent of women who believed that regular marijuana use was of no risk during pregnancy increased from 4.6% in 2005 to 19% in 2015. In a national survey study of over 200,000 women aged 18 to 44 years, marijuana use in pregnant women increased 62% during the time period 2002 to 2014. The highest rate of pregnant women reporting marijuana usage is 7.5%, which occurred in women aged 18 to 25. Current research has not discovered a risk for perinatal mortality and morbidity. Prevalence in pregnancy is 9 to 27% in all childbearing women and 23% in teens. Obstetric and maternal outcomes. Some studies suggest marijuana use during pregnancy does not appear to negatively impact obstetric outcomes. Other studies suggest marijuana use during pregnancy negatively impacts fetal neonatal outcomes. Maternal risk factors of marijuana usage during pregnancy are abrupto placentae, preeclampsia, preterm labor, stillbirth, infertility, contaminated breast milk, C-section, respiratory difficulties, dizziness, and falls related to impaired judgment. Illinois healthcare providers are required to report substance abuse use in pregnancy. Neonatal and pediatric outcomes. There is increasing evidence that prenatal cannabis use adversely impacts the neurodevelopment and growth of the developing fetus and infant, including persistent changes in higher level cognition and psychological well-being. Reports also suggest infants exposed prenatally to marijuana had a decrease in body weight, low APGAR scores, preterm birth, display withdrawal symptoms, early substance abuse use, stillborn, and a higher likelihood of needing admission to NICU. However, there is no consistent evidence that supports this theory. According to Youngin, Davis, Shadewell, and Juve, the use of marijuana during pregnancy has also been associated with signs of tremors, high-pitched cries, and an exaggerated startle response, as well as behavior and developmental delays in children. Research is limited on the harms of marijuana usage during pregnancy. Subjective data. All pregnant women should be screened for substance abuse. Screening tools assistance would be the CRAFT assessment tool. The C represents have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs. The R stands for do you ever use alcohol or drugs to relax, feel better about yourself, or fit in. The A stands for do you ever use alcohol or drugs while you are by yourself or alone. One F stands for do you ever forget things you did while using alcohol or drugs. The other F stands for do your family or friends ever tell you that you should cut down on drinking or drug use. And lastly, the T stands for have you ever gotten in trouble while you were using alcohol or drugs. Psychologically, we screen for depression and anxiety. at every visit. Psychosocially, we screen if the significant other utilizes marijuana. Objective data. Signs and symptoms of marijuana usage: tachycardia with low doses, bradycardia with high doses, orthostatic hypotension, conjunctival injection, which is red eye, hypertension, slurred speech, ataxia, nystagmus, increased appetite, dry mouth, increased respiratory rate, impaired liver function, emphysema, and bronchitis. Prenatal monitoring and evaluation. Screen all pregnant women about their use of marijuana initially and every trimester using the CRAFT assessment tool. Be non-judgmental while assessing initially and every trimester if continued uses. Asked about the frequency of marijuana use, length of most recent pattern of use, and time of last initially and every trimester if continued usage. Asked about the quantity used and the amount of money spent on a daily, weekly, monthly basis for marijuana initially and every trimester if continued use. Assess vital signs every visit. Perform an ultrasound every visit to assess fetal well-being. Complete a urinalysis test every visit. Increase frequency of prenatal visit if substance abuse continues. Screen for depression and anxiety at every visit. Monitor fundal height every visit. And an NST completion in the third trimester. Inform pediatrician about marijuana usage during pregnancy in the third trimester. Urine drug screen on baby within 12 to 24 hours post-delivery or meconium within 3 days of delivery. Discourage breastfeeding if continued marijuana usage in third trimester. Postpartum evaluation of mother for drug abuse, depression, infant bonding, and coping strategies. Plan of care. Advise smoking cessation. Assess willingness to stop. If willing, taper dosage to avoid withdrawal. Assess support system. Assess reason for smoking. Provide additional stress relieving techniques if smoking related to stress. Refer to smoking cessation program if willing. Educate on negative maternal and fetal outcomes of marijuana usage. Reassess progress at every visit. Refer to parenting class to reduce stress. Differential diagnosis related to marijuana usage. Delirium. Delirium is defined as a transient, usually reversible cause of mental dysfunction and manifests clinically with a wide range of neuropsychiatric abnormalities, as evidenced by the side effects of marijuana: fluctuation of level of consciousness, mental cloudiness, and motor abnormalities. Another differential diagnosis would be atrial tachycardia, which is a supraventricular tachycardia that does not require the atrioventricular junction, accessory pathways, or ventricular tissue for its initiation and maintenance, as evidenced by the side effects of marijuana. Which one is tachycardia?